Fantastic. So thank you very much for inviting me. And Stuart's given me the role, the remit to discuss the evolving role of the scientist, the flow cytometry scientist in blood cancer diagnostics. I think really over the past 2 decades, flow cytometry in blood cancer diagnostics has really evolved from what was originally a simple technical assay into a very sort of, I guess you call it, high dimensional diagnostic platform. And with it, the role of the flow cytometry scientist is going to be fundamentally changing. So I think to start with, it's really important to highlight why flow cytometry is so central to the diagnosis and also the management of patients with blood cancer. So we know that flow cytometry provides rapid, high informational diagnostics at a single cell level. And unlike some techniques such as immunohistochemistry, or if you think about some tests where you might need to cell sort before targeting a particular cell of interest, flow cytometry allows us to assess multiple parameters simultaneously, giving us a very detailed immunophenotypic profile of each population within a heterogeneous group of cells. I think this is really particularly critical, where we've got the acute settings where rapid lineage identification will directly influence urgent treatment decisions. So beyond the initial diagnosis, flow cytometry also plays a role in the characterization of abnormal populations. It helps us identify aberrant expressions, both at diagnosis. It helps us to identify what we call leukemic-associated aberrant immunophenotypes, or LAIPs, particularly in the MRD setting. And we know that these LAIPs represent antigen expressions that will deviate from what we call normal hemopoietic maturation. And this might include sort of asynchronous expression, where we see such things such as CD34 as an immaturity marker combined with some more mature markers. Or we may see cross-lineage antigen expression, for example, myeloid antigen expressions on lymphoblasts, or abnormal intensities, or absence of expected markers. I think when we're looking at acute leukemia, defining this LAIP at diagnosis is critical, as it provides a patient-specific sort of what we call an immunophenotypic fingerprint. And then this can be tracked over time for MRD assessment, down to levels of 10 to the minus 4, even lower, depending on where you are and what your assay performance is. However, of course, with all this technology, there are limitations, and we know that LAIPs can shift over time, particularly when we're under treatment pressure. And not all aberrancies we know are stable. And this is why many centres now will combine things such as the LAIP-based approach with a difference from normal strategy, comparing populations against established patterns of normal regeneration. So from a scientific perspective, and the scientist is identifying and validating these LAIPs, and that requires a detailed understanding of normal bone marrow immunophenotypic maturation, as well as sort of very careful panel design. So while these LAIPs remain a cornerstone of MRD detection, their effective use relies heavily on expert interpretation and integration with clinical and molecular findings. And I think through all these talks, you'll hear about this integration more and more. And flow cytometry and genetics are now tightly integrated in the diagnostic workup of blood cancers, each providing complementary information. And of course, we use flow cytometry in other applications, such as PNH testing, and also in FMH testing for fetal maternal hemorrhage. So overall, I think flow cytometry is not just a supportive tool, it's really the cornerstone of modern blood cancer diagnostics. And its importance sort of continues to grow as technologies and also the clinical demands evolve on the service. So if we think about the diagnostic pathway for suspected blood cancers, there are several complementary techniques involved. But where does that diagnostic process begin? Well, we all know it begins in the clinic, where the doctor will see the patient, they'll interview the patient, and they'll do a physical examination, look for lumps and bumps. And then we typically begin with the patient sample, and that can either be peripheral blood or bone marrow or some other sample that we can use for flow cytometry. And that first assessment, we might look down a microscope and look at the morphology, and that may suggest the presence of blasts or abnormal populations, such as maybe a mature lymphocyte expansion. And then flow cytometry plays a critical role at this point in the pathway because it provides the rapid characterization of those cells, allowing us to determine lineage, identify abnormal antigen expression, and to begin to classify the disease. And importantly, this information generated by flow cytometry frequently guides the next stage of testing. For example, specific immunophenotypic patterns may suggest a particular cytogenetic abnormality or molecular lesion, which will then direct sort of further what we call targeted genetic testing. And ultimately, it's getting all these data sets together, the morphology, the flow, the cytogenetics, and the molecular, that are integrated to produce that final diagnosis. So in many ways, flow cytometry acts as the bridge between the initial examination of the patient in the clinic through the morphological assessment and then deeper into the deeper genetic characterization of the disease. So when we look and we'll try to understand the role of how the scientist in flow cytometry is evolving, I think it's quite useful to briefly look at traditional models within the diagnostic laboratories. And we think historically the role was primarily technical. Scientists were responsible for preparing the samples, they'd operate the flow cytometer, set up antibody panels, and they'd do some sort of very initial gating of populations. And the output of this process was typically a very technical based report just describing the immunophenotypic findings. Then the interpretation of the clinical significance of those findings often historically sat primarily with the reporting hematologist or the pathologist. And this workflow was largely linear. The scientist generated the data, the instrument produced the plots, and the basic report was issued. However, as flow cytometry and technology has advanced, and we know that diagnostic complexity and the biology of blood cancers has advanced, that model has changed quite significantly. And increasingly, scientists are now involved not just in generating the data, but also interpreting complex immunophenotypic patterns and contributing to the overall diagnostic insight. So when we look at the technical evolution of flow cytometry, one of the major drivers behind the evolving role of the scientist has been the rapid development of the technology itself. Now we know that flow cytometry has been around for a long time, certainly from the initial patent that was filed by the Coulter brothers in 1953. In 1956, you could buy that box. The first commercial Coulter counter was available. And now, if we look now back to the 1990s, sort of 80s, 90s, you'd look at 2 or 3 color panels. Some places were doing 4 color panels. And most diagnostic laboratories were working with these very simple sort of panel strategies that we don't see today. And now this allowed sort of very basic lineage assignment, but provided sort of very limited immunophenotypic detail. Jump forward to sort of 2000s, we were looking at moving towards 6 to 8 color sort of flow cytometry. And now today, where we're looking at 10 to 13 color panels is what we're sort of seeing on a lot of modern instruments today, which has significantly expanded our ability to characterize cell populations. Now, I'm not going to talk about it here today because it's a whole subject on its own, and I'm certainly no expert in it. But obviously, more recently, we've had the introduction of spectral flow cytometry, and this has really pushed even further the scientist even further, because it allows the simultaneous analysis of 20 or 30 or even more markers in a single tube. And although spectral flow cytometry offers very impressive and sophisticated sort of full spectrum data capture, it still remains very much in its early stage technology, still considered by many as highly exploratory, technically demanding, and sort of still firmly rooted in the research setting rather than in routine clinical diagnostics. But I'm sure over time we will see that change. And today we know it's not uncommon to work with panels of 10 or 12 or more antigen targets. And this expansion allows us to interrogate the biology of the cells in much greater detail. But also, when you're interrogating the cells in greater detail, it introduces new challenges. And one of the main issues is what I call data dimensionality. And the number of parameters, as the number of parameters increases, the traditional manual gating can become less practical, can certainly become more subjective. And at the same time, the technical challenges such as fluorescence spillover, compensation, autofluorescence, these become really much more difficult to manage as flow cytometry scientists. Standardization is obviously another key concern. When we look at variability in instrument setup, panel design, and analysis strategies, this can lead to inconsistencies, which can be particularly problematic in the clinical setting, where reproducibility is critical. And we also sort of face increasing demands for increased sensitivity. We've already touched on MRD, especially where we're looking to trying to identify extremely rare cell populations with very, very high confidence. So to address these challenges, the field is moving towards what we would consider more computational approaches. And this can introduce, we can talk about automated gating, clustering algorithms. And now there are machine learning tools that can handle high dimensional data quite objectively. And at the same time, initiatives such as Euroflow are helping to standardize protocols and improve harmonization across laboratories. But ultimately, as I think analytical complexity increases, it's not just about generating more data, it's about ensuring that we can interpret that data reliably in the clinical setting. And I think another key area where we see the scientist evolving is in panel design and standardization. Traditionally, and still in most laboratories today, clinical flow cytometry testing is based on what we call laboratory developed panels or laboratory developed tests, LDTs. And these are designed locally on evidence-based practice, but take into account factors such as instrument configuration, available reagents, and also the clinical requirements and laboratory's expertise for your service. And this approach, obviously, by having LDTs, offers some flexibility, but it also introduces some sort of variability between laboratories in both marker selection and interpretation. And over the past decade, there's been a real push towards a greater understanding and a greater standardization through initiatives such as the Euroflow Consortium, which has validated panels for both diagnostic and MRD assessment. However, in the UK, in routine practice, many laboratories still continue to use either adapted or fully laboratory developed panels, or maybe a hybrid mixed approach, rather than adopting consensus panels in their entirety. But while standardization offers clear advantages, in practice, we're having to balance this with a number of sort of real world constraints within the diagnostic laboratory. I think reagent costs are a significant factor, particularly as panels are becoming larger and more complex. And certainly, I know we've got over 71 countries who have registered for this. The finances for different countries are going to be different. Cytometer configuration also plays a role. Not all laboratories will have access to the same number of lasers, the same number of detectors, which will limit how closely standardized panels can actually be replicated in local services. In addition, staff expertise, staff training are very critical. We know that high parameter panels require confidence in both the initial setup in the laboratory, and the interpretation, and that will vary across laboratories. And of course, we can't forget workload pressures, because workload pressures mean that any panel needs to be very practical. It needs to be efficient and sustainable within a busy service environment. So then, rather simply than just adopting standardized panels, many laboratories develop adapted approaches that balance best practice with what is feasible for your local service. And I think, again, this is where the role of the scientist becomes particularly important, because it's the scientists who are increasingly leading on panel validation, panel optimization. We're the ones who are selecting the appropriate markers, ensuring robust performance, and structuring these panels in a way that captures the lineage, the maturation, and of course, aberrant antigen expression. So in effect, we as scientists, we're the ones who are ensuring that panels are not only technically sound, but also clinically meaningful within their specific diagnostic setting. And if we're talking about how the role is expanding, well, traditionally, flow cytometry was largely just focused on detecting abnormal populations. However, with our expanding understanding of leukemic biology, the role has shifted towards interpreting complex immunophenotypic patterns in a much more deeper and a much more meaningful way. I think it's safe to say that we know now far more about normal hemopoietic differentiation, which means distinguishing between normal regenerating cells and true leukemic populations can also be somewhat subjective. And this is particularly important in identifying subtle aberrancies or phenotypic shifts, particularly in early blast populations. And this becomes even more critical in the MRD setting, where we may be identifying a single abnormal cell in amongst hundreds of thousands to millions of normal cells. And interpretation at this level really relies heavily on gating strategy. It will rely on things such as marker selection and, of course, experience, especially as we know that a lot of modern therapies, particularly in clinical trial settings, can shift antigen expression. And it really does challenge established detection strategies. So the scientists, we have to continually adapt and shift to these therapeutic advances to ensure that we're capturing the accurate disease assessment. I think at the same time, as advances in technology have allowed us to use increasingly complex high-dimensional panels, whilst we improve the resolution, they're also going to introduce some ambiguity, meaning we can't just rely on a simple panel of markers, but instead we have to interpret patterns across multiple parameters. I think importantly, flow cytometry findings, they can't be viewed in isolation. Tom mentioned this earlier. There is no one service that can work in isolation. We can't work in silos. They have to be integrated with molecular and genetic data to provide an accurate picture of disease classification and, of course, disease prognosis. Ultimately, the interpretations that we make will have direct clinical consequences impacting the diagnosis, the risk stratification, and the treatment decisions for the patients that we serve. And this really places a massive growing responsibility on the scientists to ensure the analysis not only sort of technically accurate, but also biologically and clinically meaningful. So we have morphology, we have flow cytometry that defines the immunophenotypic profile of that malignant population. But of course, in parallel, we've got the genetic and molecular analysis, such as cytogenetics, FISH, and next-generation sequencing. And these will, of course, identify the underlying genomic abnormalities that drive the disease classification and the prognosis. And importantly, these modalities inform each other. There are immunophenotypic patterns that can suggest and may help with specific gene lesions. We know APL is a good one for an example, whilst also the genetic findings can also help explain some sort of unusual or ambiguous flow results. So they really do go working hand in hand. So this is a case that we have here. We know this is an AML case with a known fusion. I can tell you this is a blood film here. It's just a small snapshot of the blood film. If you had the full blood film, I could tell you there was some differentiation to mature neutrophils. Some of them looked a little bit dysplastic. There was some eosinophilic differentiation. But you can see here we've got some typical blast cells in the top left-hand side. And these blast cells have a slight indentation in the nucleus, representing a sort of Golgi zone. And there is a very thin sort of fusiform owl rod within the nuclear Hoff there. If we look at the flow cytometry plots, we've got the red cells, the neutrophils, the green are the monocytes, and that's confirmed by CD14, CD36 expression. If you don't have sort of markers like that, you could almost say that these monocytes are sort of, could they be considered degranulating neutrophils? So it's really important that you have a good panel that will sort of differentiate your markers, your cells of interest. Then we've got the cells that are in this sort of cyan color, which are the blast cells, and we've got magenta for the lymphocytes. And you can see here that the leukemic cells express this phenotype that has a high intensity of CD34. We've got CD13, HLA-DR, and MPO with a weak CD33 expression. You may also see here that we've got some aberrant expression of some lineage markers. We've got CD19 and CD56 positivity on the myeloblasts, and we can see some CD56 on the maturing neutrophils. Now, I'm not going to talk about genetics because I'm certainly no expert in genetics, but this is a FISH. This is FISH for an interphase nucleus of this patient that has a normal RUNX1-XT1 fusion signal pattern. You've got one red signal for a normal RUNX1-XT1, one green signal for the normal RUNX1, and you've got some fusions there in that bright yellow color. Really great if you're not colorblind. I'm unfortunately colorblind, so I have to go on what people tell me. But yeah, obviously this is an important translocation. We know that sort of might fit with the morphological and also the flow cytometric pattern that we saw earlier. But when we talk about the biology of the disease, we know that AML is not just acute myeloid leukemia. We talked about how many thousands of subclassifications there are. And this is a circus plot on the right-hand side, which just illustrates sort of co-mutational patterns in AML, with the outer label sort of representing a gene and the connecting chords indicating some recurrent occurring mutations, with thicker chords reflecting stronger associations. Now, in the example that I showed, this was an AML with a RUNX1-XT1. We know it's a core binding factor leukemia, which generally has a favorable prognosis. But you can see that the circus plot demonstrates that AML is very genetically heterogeneous, and co-mutations may impact risk for many of the leukemias. So overall, accurate classification relies on an integrated multidisciplinary approach, enabling more precise diagnostics, prognostics, and also treatment selection for our patients. So as flow cytometry becomes more complex, we're increasingly seeing the introduction of automation and AI into our workflows. And this includes things such as automated gating tools, which can rapidly identify cell populations, as well as machine learning approaches that analyze high-dimensional data and detect patterns that may not be immediately obvious to the human eye. And there are already software packages out there doing this for flow cytometry. Now, we know that automation may improve speed, which certainly can be beneficial, but more importantly, it will support standardization. It will sort of help reduce intra-operator variability and making results more reproducible across laboratories. However, there are important risks that we need to consider when we look at automation and AI, because there is the potential for an over-reliance on these tools, particularly if results are accepted without clinical review. In addition, automation becomes as automation is to become more embedded. There's sort of real concern around the gradual loss for expertise within the laboratory workforce. So I think we have to be very careful that we don't over rely on technology and we don't lose our expertise because of it. And going forward, we know that artificial intelligence is becoming increasingly important for many branches of medicine, but it will also support flow cytometry by helping us interpret large, complex data sets. And it will do this more efficiently and more consistently. We know AI tools could help identify patterns highlighting abnormalities and reducing variability between operators. We know it can help with automated cell grouping. We know algorithms such as k-means can cluster similar cells together without manual gating. And this can help reveal very distinct or rare populations that may have diagnostic relevance. We know that there are supervised models out there now that can be trained on own disease patterns, on your known personal disease patterns within your service. And they can be used to help support recognition of similar profiles in new samples, again, improving reproducibility. And now I'm certainly no expert in AI, but deep learning methods are there that can process complex marker combinations, and this could assist in the identifying of subtle immunophenotypic changes, particularly on therapy. And there are obviously better visualization tools, such as TNSE and UMAP, that can reduce these large data sets into much more simplified 2D maps, making abnormal populations much easier to see at a glance. But despite all these advances in technology, the role of the expert scientist in flow cytometry remains absolutely central in leukemia and blood cancer diagnostics. We know that flow data is inherently complex to interpret, and distinguishing between normal, regenerating, malignant populations, particularly in the post-treatment setting, when we're looking at MRD, really requires a deep understanding of hemopoietic maturation, the disease biology, and technical limitations. And these are not decisions that can be fully standardized or delegated just to algorithms. I think it's safe to say that expert scientists are very critical at every stage of the diagnostic process, through thoughtful panel design and validation, through recognizing what artifacts are, what subtle aberrancies there are, or unexpected phenotypes. And this ultimately ensures that results are interpreted in the context of the clinical and molecular findings. And importantly, as scientists, we play a key role in safeguarding quality, questioning automated outputs, identifying these discrepancies, and knowing when results don't fit with the clinical picture. Now, as diagnostics becomes more integrated and data-rich, this scientist's role isn't diminishing in any way. I'd say it's evolving more. So if we look at where the flow cytometrist of the future sits, Well, specifically for blood cancer diagnostics, we know that it's continuing to evolve into much more sort of hybrid and integrated position. As I said, we're no longer just technical operators. We're increasingly functioning as data scientists. We're managing and interpreting high dimensional data sets generated by very advanced platforms. At the same time, our role as clinical interpreters is expanding. We're expected to contextualize immunophenotypic findings alongside morphology and clinical information. And this may also help interpret genetic findings, thus contributing directly to the diagnostic and monitoring decisions within multidisciplinary teams. Now, alongside this, we know that quality, of course, is going to remain a core responsibility of what we do. As workflows become more automated, there is a significant need for robust validation and standardization, and critical oversight becomes really more important as a scientist when we're dealing with these workflows. So scientists really will play a key role in ensuring that new technologies are, I'd say, implemented safely and that results remain reliable and clinically meaningful. So to support this shift, I think the required skill set as a scientist is changing. We know that advanced data analysis is becoming essential, including familiarity with multidimensional tool analysis. And this is obviously being increasingly driven by things such as AI platforms. And this needs to be combined with strong clinical knowledge, particularly in leukemia biology, and a clear understanding of how these new tools work. But obviously, their strengths is a key one, but also we need to be really clear about the limitations of these tools when we're talking about blood cancer diagnostics. So really just to finish up, I think the sort of key take-home message is ultimately I was asked to talk about the future role of the scientist and where we sit. And I think the future scientist sits at the intersection of technology, biology, and clinical care, acting as almost like a bridge between complex data and real-world patient management. And that will obviously impact making meaningful clinical decisions. And I think really to finish up, I think behind every plot is a diagnosis, and that's really important to remember, because as scientists, as flow cytometry scientists, we're the ones that turn the data into patient diagnosis and ultimately patient care. So hopefully that's. I know we've got lots of countries who've joined around the world. Hopefully that has given you some food for thought about how we can sort of work together as a scientific community and how our roles will evolve. So thank you very much, and I'll end the show there.
Thank you ever so much, Tim. As you say, a lot of food for thought there. We're running a little bit behind, so I'm going to limit this to one question, if that's okay.
Yep.
So there is a growing interest in AI-assisted gating and population identification. How confident are you that these tools are ready for routine diagnostic use, and what safeguards do you think are essential before widespread adoption?
Absolutely. I think this is a very critical question, and this is my personal views on this subject. I'm very much skeptical at the moment, as it is very much in its infancy. There are some fantastic tools. I'm not going to mention them. There are companies out there who have AI end-to-end AI cytometry solutions that will sort of they show increased reproducibility, making the workload more flexible. They're very much in its infancy. These companies are very early adopters, so I think it's a really wait and see. But I think there was a question in a previous talk about what about litigation of data? And I think that's really important. The scientist is responsible for the data. We're the ones who have to pick up if there's something abnormal or if there's something there's some deviation from what the AI throws out. So I think we need to evolve to understand what AI is, how it will impact flow cytometry. And I think we need to be very clear about when we talk about litigation, where the liability sits, because ultimately as scientists, we're the ones who are sort of doing the dot plot analysis, and AI is, I think we consider it as a supportive tool rather than a tool that's going to take over.
Fantastic, thank you, Tim. So as I say, we've got quite a few other questions, so we'll send them to you separately if that's okay.
Yep, thank you.